Okay, as usual, when we talk about function of a particular system, and then we talk about dysfunction. So the immune system's fabulous until it doesn't work, and then it's not so fabulous. So we're going to talk about immune system dysfunction. Same learning objectives. For the whole chapter, I'll always have the same learning objectives, even though I divide it up into smaller PowerPoints. So one of the things that can go wrong with the immune system. So I talked about suppressor T cells that stop the immune response when it's gotten out of hand or when it's done. Like, okay, done, we're safe. So sometimes the immune response doesn't recognize your cells as self cells. So the one of the jobs of the immune response is to recognize, distinguish self from non-self. So the non-self cells it keeps out, and the self cells it doesn't bother. It just lets them do their job. So when the immune response starts to act on the body's own functioning cells, it doesn't recognize those cells as self cells. That is autoimmune disease. So in most cases, we don't know what causes autoimmune disease. What makes the immune system suddenly decide that its own cells are enemies? We don't know. So it's idiopathic. Most diseases, autoimmune diseases, are idiopathic. A lot of them are believed to result from either genetic disposition or genetic disposition plus an environmental trigger like a viral infection. So one of the peripheral nerve diseases that we'll talk about towards the end of the quarter. It's called Guillain-Barré disease. It's the immune system. It's an autoimmune disease. The immune system attacks the myelin sheaths and peripheral nerves, and so the environmental trigger is thought to be Epstein-Barr virus or some other viral infection that all of a sudden makes the immune system recognize the myelinating cells as enemies. It, there's something about the Epstein-Barr virus or some of the other viruses that trigger the immune system to react that way and start destroying the myelinating cells, basically. So the immune response is triggered and it's detrimental to body function because now it's attacking its own healthy tissues and organs. That's not good. So we're going to talk about some specific autoimmune conditions that we commonly see in physical therapy practice. There are tons of other ones. This isn't a comprehensive list. So two that are super common that we see all the time in PT. Type 1 diabetes mellitus. So we have, and we'll talk way more about diabetes next quarter when we talk about the endocrine system. But there's type 1 and type 2. Type 1 is less common, but it's the autoimmune version. So the target cells in type 1 diabetes mellitus are the beta cells in the pancreatic islets of Langerhans, or now they call them just pancreatic islets. The trend is to go away from naming things after people. So those beta cells are the cells that create insulin. And insulin is the hormone that regulates glucose metabolism, super important to every single one of our cells. So when the beta cells are destroyed by an autoimmune reaction, then insulin production ceases. And the symptoms are fatigue because our cells aren't getting the nutrients they need, lethargy, confusion, polyuria, which means you pee a lot, glucosuria, which means when you do pee, you have glucose in your urine because you have excess glucose circulating around in your body, and increased thirst. And when we talk specifically about the endocrine system, we'll go into more detail on that. So without insulin, glucose can't enter the cells and it leads to high blood glucose, which causes a lot of other issues in the body. Rheumatoid arthritis, on the other hand, and again, there are other versions of arthritis, and we'll talk about those. But rheumatoid arthritis is the autoimmune version. And the target of the immune system is the joint capsule and cartilage in the synovial joints. The effects of the immune system attacking the joint capsules and the cartilage is warmth, swelling, stiffness, and pain, inflammation of the joints causing those. It progresses into joint destruction. It destroys the joint capsule, ligaments, and articular cartilage. So a lot of times people with rheumatoid arthritis end up getting multiple joint replacements. And it's one of those diseases that has remission and exacerbation periods, so or acute and chronic periods, if you want to think of it that way. The systemic effects of RA can also affect skin because it affects connective tissue, lungs, heart, and blood vessels. So, with diabetes, type 1 diabetes, it also affects a lot of microcirculation, so it can affect all your organs and nerves, everything. So, lupus or systemic lupus erythematosus, or SLE, easier to say, the target is connective tissue throughout the body, not just in the joints. So the symptoms tend to be joint pain and stiffness, skin rashes. There's a distinctive butterfly rash that's on the face from a lupus flare, fever, malaise, and fatigue. It can affect almost all your systems, heart, blood vessels, lungs, kidneys. The problem with lupus is it's hard to pin down because it can affect so many different organ systems. The symptoms can be distracting to whoever is trying to diagnose this for you. Graves' disease, and now they're taking away all my apostrophe S's. And so now I think it's just called grave disease. Anyway, Graves' disease. The autoimmune target is the thyroid stimulating hormone receptors, so TSH receptors. So Graves' disease is the most common cause of hyperthyroidism, which is so you have a higher metabolism, you're warmer, you have increased heart rate and blood pressure, weight loss because that increased metabolism, insomnia, tremor, diarrhea, thyroid eye disease. Often you see people with Graves' disease that have exophthalmos, which is the protruding eyes, and goiter, which is when the thyroid gland grows big, you can see it in the neck. Myasthenia gravis, the target is acetylcholine receptors at the neuromuscular junction. So it results in muscle weakness, especially in muscles that have to work repetitively over and over again, eyes, face, swallowing muscles. A lot of times you have to work a lot on energy conservation with people with myasthenia gravis because they tire easily. A lot of autoimmune diseases are treated by medications, and they're immunosuppressant medications. So then that creates its own problems. MS is an autoimmune disorder, and just like most autoimmune disorders, it's idiopathic in etiology, and it's considered to be there's probably a genetic disposition with an environmental trigger. The target of the autoimmune response is the myelin sheaths covering motor and sensory nerves in the brain and spinal cord. So you can have a variety of symptoms, primarily motor weakness, sensory loss, visual deficits, and autonomic nervous system disruptions. A lot of people early on, before they're diagnosed with MS, a really large percentage of people report visual issues. I've had a couple people tell me, I've worked with a lot of people with MS. I'm working in outpatient neuro for 70 years. I've had a lot of people tell me that it felt like they were looking through a screen. Kind of interesting. So the mechanism of the disease is autoimmune destruction of myelin interferes with nerve signal transmission. And so lots of autoimmune conditions require ongoing rehabilitation services. The ones that we mentioned here, there are tons of other ones. And so you will form, career-long relationships with a lot of patients that have these diseases. And understanding the underlying immune dysfunction helps you provide appropriate care and recognize potential complications. So really important to understand this. So another immune response that we talk about are hypersensitivity responses. So hypersensitivity is an exaggerated or inappropriate immune response that can cause tissue damage or dysfunction. So one of the areas that I think probably a lot of us have experienced in hypersensitivity reactions is allergies. So allergies are immune system responses. They're hypersensitivity responses. So there are four different types. And type 1 is what allergies are considered. So immediate. You have a response minutes after exposure. So I can tell every spring when my neighbor's ornamental plum blooms because I have that immediate allergic response. I don't have to look out there. I can feel it in my sinuses. Um, one of the uh, disadvantages, well, they all have disadvantages, but you can have anaphylaxis, which is an extreme reaction. The allergic response produces histamines. The histamines cause vasodilation. Excessive vasodilation causes your blood pressure to drop, and that is in essence anaphylactic shock. You can die from that, but hopefully you recognize the symptoms and don't die from it. Type 2 is called a cytotoxic hypersensitivity reaction, and it is a little bit slower, hours to days. Um, Blood transfusion reactions are kind of usually the primary example of cytotoxic. So I have type B blood. If I get a type A um, transfusion, my body recognizes the antigens on the type A blood erythrocytes as foreign and it destroys them. So that's not good. Type 3 is immune complex hypersensitivity, and that happens over days to weeks. Um, that's lupus and rheumatoid arthritis are a type 3 hypersensitivity reaction. And type 4 is what's called a delayed reaction, which happens more than a day and usually requires more than one exposure to trigger it. So poison ivy, TB skin test, the little skin test that they give you. Now they have the blood test that they do, the quantiferon gold, which doesn't provoke the immune response. But latex allergies are type 4 hypersensitivity. So in the old days, before they had nitrile gloves and medical people used latex gloves, a lot of people who had been in the medical field for a long time developed latex allergies from continuous exposure to those latex gloves. So type 1, examples of type 1 are like hay fever, asthma, um, extrinsic asthma is, there are two different types of asthma. We'll talk about it. We'll talk about it in another chapter. But extrinsic asthma is a reaction to allergens. Food allergies are type 1 hypersensitivity reactions and anaphylactic reactions. One time I always do the Jingle Bell Run to raise money for arthritis. And one time I was on the hospital team and they gave us these scarves. It had the little hospital logo on it. And usually before I wear something like that, I'll wash it. But they gave it to us on the morning of the race, and so I just put it around my neck. And about halfway through, I felt like I was starting to have a reaction to it. And so the finish line is pretty close to my house. And so instead of going to the finish line, I peeled off and went to my house. And I had hives all over my neck. It's a reaction. And so I took some Benadryl and laid down and went to sleep and recovered from it. Benadryl is an antihistamine, which counters the effect. So the mechanism is the IgE, which is one of the type of antibodies, binds to mast cells and basophils. The mast cells release histamine, and the histamine gives you the effect. So the symptoms are vasodilation, smooth muscle contraction, mucus production, and tear production. I think any of us that have environmental allergies or food allergies have experienced these. The timeline is usually within minutes of exposure. So, I mean, it doesn't take very long to run a 5K and or even to walk it. And so I put that scarf on, and before I was even done, I had the reaction. The severity can range from mild, like when my neighbor's ornamental plum tree blooms, to life-threatening anaphylactic shock. If your body produces enough histamine to cause so much vasodilation that your blood pressure drops, that can be life-threatening. So type 2, the mechanism of type 2 hypersensitivity, and that's like the blood transfusion reaction, the antibodies bind to the antigens on the body's own cell surfaces, and it results in inflammation and cell death. So myasthenia gravis, Graves' disease, and blood transfusion masses are all type 2 hypersensitivities, and it develops over hours or days. Type 3 hypersensitivities, the mechanism is the accumulation of immune complexes, which when antibodies bind to antigens, usually they get the cytotoxic T cells come and kill the cells and the macrophages clean up the mess. But sometimes you get buildup, accumulation of the immune complexes in joints and blood vessels and the walls of organs. Um, and they build up over time, which is why it develops over days, weeks, or months. And it results in chronic inflammation because you have too many immune complexes that aren't being broken down. So, lupus, rheumatoid arthritis, serum sickness, and post-streptococcal glomerulonephritis, there's a word for you. So, lots of examples of a type 3 hypersensitivity. No fun. Type 4 or delayed hypersensitivity, the mechanism is a cell-mediated response. So you get an activated T cell. There's no antibodies involved. Activated T cells destroy the target cells. So in poison ivy reactions or type 1 diabetes or MS or irritable bowel syndrome, those are all type 4 hypersensitivity reactions. It generally takes more than a day and often much longer to develop these reactions. So immunodeficiency is the reduced ability of the immune system to fight infections and diseases. So there are two different kinds, primary and secondary. So primary is congenital, meaning you're born with it. So it could be a genetic disorder. It's present from birth, pretty rare. Your body's either your T cells, B cells, or complement, which is part of the chemical messengers that your immune cells create, or your bone marrow can be affected. It's often apparent earlier in life. If it's a bone marrow issue, then bone marrow transplant is often the treatment for primary immunodeficiency, or sometimes gene therapy that's being developed. And so we'll see what comes of that because that's probably a little less drastic than bone marrow transplant. Secondary or acquired immunodeficiency develops later in life, and it's much more common. So there are lots of different causes, and if the cause is treatable, then it can be reversible. So sometimes the cause is that you're on long-term steroid treatment for another disease, and that causes acquired immunodeficiency. And if you go off the steroids, it fixes it. So that's good. There are other things that are not reversible. So common causes of secondary immunodeficiency, viral infections, so HIV/AIDS, and we'll talk about that in detail, is a primary example of a viral infection causing immunodeficiency. Environmental factors, including malnutrition, toxic exposure, and chronic stress, can diminish your immune system. So those things can be fixed. Medical treatments like immunosuppressive therapy for organ transplants, well, you have to be on that as long as you want to continue to use the transplanted organ, and you usually do. Cancer treatments like chemo and radiation, because they not only kill the cancer cells, they also kill some of your normal cells, and long-term steroid use. Very young, underdeveloped immune responses or very old, declining immune function can be secondary immunosuppression. So some of those are fixable, some of them aren't. Some of them you just have to live with. So HIV is the most common infectious immunodeficiency. So you can't just get HIV from casual contact. If somebody coughs on you, you can't get HIV. You have to share blood or breast milk or other body fluids. So unprotected sexual activity is a common way to transmit HIV. Intravenous drug use because you're sharing blood. Mother to child. So if the mother has it, the baby gets it in the placenta and breast milk. And contact with blood or other body fluids. So early on in the HIV timeline, the if like say you accidentally the you're a healthcare professional and you're giving someone an injection and you try to recap the needle and you accidentally stab yourself, that's a way that you could get exposed. So the as a response to the HIV epidemic 30 years ago, the 40 years ago, the CDC developed standard precautions, and the standard precautions are basically that treat all body fluids as though they're infected and just take precautions. So that's pretty smart. So there are three stages of HIV infection that are progressing to AIDS, which is acquired immune deficiency syndrome. Acute HIV infection, the first 2 to 4 weeks post-infection, and you have like typical infection symptoms: fever, rash, joint pain, muscle pain, and headaches. You might have the flu, with those symptoms. That's when you have the highest transmission risk because it's often mistaken for the flu because the symptoms are similar. The During the acute stage, HIV is rapidly reproducing, and the CD4 cell, the helper T cells, the count is dropping. So every virus has a target cell that it prefers, and the HIV virus prefers those CD4 cells. So patients with HIV and AIDS need careful infection control measures due to compromised immune systems. So you don't see it as much. You don't see people with acute HIV infection as much anymore because so many preventative measures are in place, which is lovely. But still, if somebody has that, their immune system is being suppressed, and you have to make sure that you're not making them sick with something else. So in stage 2, it's the clinical latency or asymptomatic phase where you have minimal or non-observable symptoms. And most patients are being treated on antiretroviral therapy um, at this point. And with treatment, they can live several decades with good quality of life. And the stage can last about 10 years without treatment. But the problem is during this time, you're still immunosuppressed. And so you can get secondary infections. And most people die of secondary infections, just so you know. So in stage 3, that's considered AIDS, full-blown AIDS, sometimes they call it. The diagnostic criteria is that your CD4 helper T cell count has to be below 200 cells per milliliter or square millimeter. Cubed, it's a milliliter. Anyway, microliter. Anyway, they have cell count criteria. Plus, you have to have acquired some opportunistic infections. Thrush is one that's common in people with that are immune suppressed. It's an oral yeast infection. Your life expectancy without treatment, if you're in stage 3, is about 3 years, and with treatment, it's variable. So there are effective treatments now, but the primary cause of death is opportunistic infections because your immune system is suppressed. Other causes of death include cancer. There's a particular kind of cancer that's called Kaposi sarcoma that's associated with AIDS, and it's bad. Well, no cancer is good, but cardiopulmonary disorders or neurological conditions. So variable outcomes. So the clinical implications for us is infection control is job one. Safety and infection control. Hand hygiene. I cannot express how important it is to wash your hands on a regular basis or use hand sanitizer. Follow the PPE protocols that are set forth in your facility. Maintain aseptic technique when necessary. And recognize immunocompromised patients so you can take extra measures. Patient populations that require extra caution are very young or elderly patients. In PT, elderly patients are generally our people that we're working more with. Very young kids usually only need PT if they have long-term neurological or congenital diseases. Usually kids with minor orthopedic things, they heal quickly by themselves. So those kids might be um, more vulnerable. Patients on immunosuppressive medications, so anybody who's had an organ transplant or who's on Humira for rheumatoid arthritis or anything like that, is someone who requires extra caution. Cancer patients undergoing treatment, organ transplant recipients, people with HIV or AIDS. So all of those people require extra caution. So for exercise, moderate exercise supports immune function. We know that. You want to avoid overexertion in immunocompromised patient because overexertion can hinder your immune system, and they're already immunocompromised. So you want to monitor them for signs of infection or illness because they're more susceptible. So the key concepts, the types of immunity, innate, passive, and adaptive. Immune responses, humoral and cell-mediated pathways, the factors that affect immunity, exercise effects, autoimmune diseases, hypersensitivity, you should know all four types, immunodeficiency, and understanding immune function helps us protect our patients and ourselves while providing safe, effective care. That is the upshot. So think about these clinical scenarios. How would you modify treatment for a patient that's on long-term steroids? What precautions are needed when treating an organ transplant recipient? How might autoimmune conditions affect rehabilitation outcomes? And what signs might indicate that a patient is immunocompromised? So remember, when in doubt, ask about a patient's immune status or infection control needs, and always ask your supervising PT or consult facility protocols for infection control. So, any questions about the immune response and its clinical implications? Bring them to office hours and we'll talk about them.